What is the role of the anaesthetist in the management of postpartum hemorrhage? The management of postpartum hemorrhage requires a multidisciplinary approach. The anaesthetist plays a crucial role in maintaining hemodynamic stability and, if necessary, in determining and administering the most appropriate method of anesthesia. While general anesthesia in obstetric patients is associated with increased morbidity and mortality when compared with regional anesthesia, due to the physiological changes that occur in pregnancy, it may be preferable in patients who are hemodynamically unstable or who have a coagulopathy. The patient may need high dependency or intensive care in the postoperative period. An obstetric early warning score system would help in the early identification of continuous bleeding, especially in cases which are not apparent, as recommended by Center for Maternal and Child Inquiry. Arrest the bleeding. What methods should be employed to arrest the bleeding? Clinicians should be prepared to use a combination of pharmacological, mechanical, and surgical methods to arrest postpartum hemorrhage. These methods should be directed towards the causative factor. Pharmacological and mechanical strategies. When uterine atony is perceived to be a cause of the bleeding, then a sequence of mechanical and pharmacological measures should be instituted in turn until the bleeding stops. The most common cause of primary postpartum hemorrhage is uterine atony. The initial management of PPH should therefore involve measures to stimulate myometrial contractions. The following mechanical and pharmacological measures should be instituted or administered in turn. Palpate the uterine fundus and rub it to stimulate contractions, rubbing off the fundus. Ensure that the bladder is empty. Foley catheter, leave in place. Oxytocin 5 international units by slow intravenous injection, may have repeat dose. Argomethrin 0.5 mg by slow intravenous or intramuscular injection, contraindicated in women with hypertension. Oxytocin infusion 40 international units in 500 ml isotonic crystalloids at 125 ml per hour unless fluid restriction is necessary. Carboprost 0.25 mg by intramuscular injection repeated at intervals of not less than 15 minutes to a maximum of 8 doses, used with caution in women with asthma, and misoprostol 800 micrograms sublingually. Surgical treatments. If pharmacological measures fail to control the hemorrhage, surgical interventions should be initiated sooner rather than later. Intrauterine balloon tamponade is an appropriate first-line surgical intervention for most women where uterine atony is the only or main cause of hemorrhage. Uterine balloon tamponade. Tamponade using various types of hydrostatic balloon catheter has superseded uterine packing for the control of atonic postpartum hemorrhage. Case series have used a Foley catheter, Bakri balloon, Sangs-Taken Blakemore esophageal catheter, and a condom catheter. The urological Rush balloon has been described as preferable by virtue of larger capacity, ease of use, and low cost. A positive test, control of postpartum hemorrhage following inflation of the balloon, indicates that laparotomy is not required, whereas a negative test, continued postpartum hemorrhage following inflation of the balloon, is an indication to proceed to laparotomy. The concept of balloon tamponade as a test serves to affirm its place as first-line surgical management. There is no clear evidence on how long the balloon tamponade should be left in place. In most cases, 4 to 6 hours of tamponade should be adequate to achieve hemostasis and ideally, it should be removed during daytime hours in the presence of appropriate senior staff in case further intervention is necessary. Conservative surgical interventions may be attempted as second line depending on clinical circumstances and available expertise. Hemostatic suturing. The best-known version, described by B. Lynch in 1997, requires hysterotomy for its insertion and is particularly suitable when the uterus has already been opened for a cesarean section. In 2002, Heyman et al. Described a modified compression suture which does not require hysterotomy, and success in 10 out of 11 women managed with the suture has been reported. Double vertical compression sutures have proved effective in treating postpartum hemorrhage due to atony in placenta previa. These may have a dual action of reducing uterine blood flow and compressing the bleeding surface. Risk factors for a hysterectomy included increasing age and vaginal delivery. In addition, a prolonged delay of 2 to 6 hours between delivery and uterine compression suture was independently associated with a 4-fold increased risk of hysterectomy. This emphasizes the need for careful postpartum evaluation of blood loss to avoid a prolonged delay in hemorrhage recognition. Compression of the aorta may be a temporary but effective measure to allow time for resuscitation to catch up with the volume replacement and the appropriate surgical support to arrive. The judgment of senior clinicians, taking into account the individual's woman's future reproductive aspirations, is required in deciding the appropriate sequence of interventions. Stepwise uterine devascularization and internal iliac artery ligation. Stepwise uterine devascularization describes the successive ligation of one uterine artery, both uterine arteries, low uterine arteries, one ovarian artery, and both ovarian arteries in the management of postpartum hemorrhage. When internal iliac artery ligation is being considered, a senior gynecologist or vascular surgeon should be informed and involved since this technique requires a high degree of surgical skill and training and may be associated with ureteric injury. Selective arterial occlusion or embolization by interventional radiology. Arterial embolization for treatment of postpartum hemorrhage suggests that the intervention does not impair subsequent menstruation, fertility, and obstetric outcomes. Selective arterial occlusion may also be effective after failed internal iliac artery ligation. Hysterectomy. The decision for hysterectomy should be made by an experienced consultant clinician, and the decision preferably discussed with a second experienced clinician when feasible. Early recourse to hysterectomy is recommended, especially where bleeding is associated with placenta accreta or uterine rupture. Hysterectomy should not be delayed until the woman is in extremis or while less definitive procedures with which the surgeon has little experience are attempted. The procedure should be carried out by a surgeon who is experienced in carrying out hysterectomies. Subtotal hysterectomy is the operation of choice in many instances of postpartum hemorrhage requiring hysterectomy unless there is trauma to the cervix or a morbidly adherent placenta in the lower segment. Intensive and high dependency units and postpartum hemorrhage care. In 2006 to 2008, Center for Maternal and Child Inquiry report identified that 3 deaths were due to lack of optimal care following postpartum hemorrhage, and in particular, a lack of routine observation in the postpartum period. Sequential reports have recommended the use of MEOWS charts to alert caregivers to abnormal trends and hemodynamic measurements. Secondary postpartum hemorrhage is defined as abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally. How should secondary postpartum hemorrhage be managed? The causes of secondary postpartum hemorrhage are numerous and include endometritis, retained products of conception, and subinvolution of the placental implantation site. The management of women presenting with secondary PPH should include an assessment of their hemodynamic status, an assessment of the blood loss, and an evaluation of the woman's concerns. In women presenting with secondary PPH, an assessment of vaginal microbiology should be performed, high vaginal and endocervical swabs, and appropriate use of antimicrobial therapy should be initiated when endometritis is suspected. A pelvic ultrasound may help to exclude the presence of retained products of conception, RPOC, although the diagnosis of retained products is unreliable. It has been proposed that color flow Doppler imaging should be included in the evaluation of the postpartum uterus. Although there is no strong evidence to support its use may facilitate the diagnosis of pseudoaneurysms and arteriovenous malformations, which are rare but recognized causes of secondary postpartum hemorrhage. Surgical evacuation of the uterus for retained products of conception is not without morbidity and can result in uterine perforation, equivalent to 1.5%, and Asherman's syndrome. It is therefore recommended that surgical evacuation of retained placental tissue should be undertaken or supervised by an experienced clinician. An appropriately trained clinician may consider performing uterine evacuation under direct ultrasound guidance. Risk management. To ensure optimal management of postpartum hemorrhage, every unit should have a multidisciplinary protocol with which staff should be familiar. Updates on the management of obstetric emergencies, including the management of postpartum hemorrhage, are a proactive approach to risk management. Skills drills should ensure that all members of staff, including those working in the transfusion laboratory, are aware of their role in the management of postpartum hemorrhage. A systematic review of the effectiveness of multidisciplinary simulation training in obstetric emergencies, including postpartum hemorrhage, showed that teamwork training in a simulation setting resulted in improvement of knowledge, practical skills, communication, and team performance. Training in a simulation center does not further improve outcome compared with training at a local unit. The Royal College of Obstetricians and Gynecologists recommends that all cases of PPH with an estimated blood loss of more than 1,500 milliliters should be the subject of a formal clinical incident review. Documentation. Accurate documentation is important for further clinical management, continuity of care, and teamwork. In addition, inadequate documentation can contribute to the likelihood of there being medico-legal consequences. The team member recording events on the structured proforma, the scribe, is crucial in the management of postpartum hemorrhage. The proforma is effectively a checklist of available interventions, and team leaders should communicate with the scribe during the PPH to ensure that no steps have been omitted. Postpartum hemorrhage should be notified through a clinical incident reporting or risk management system. It is important to record the staff in attendance and the time they arrived, the sequence of events, the administration of different pharmacological agents, their timing and sequence, the time of surgical intervention where relevant, the condition of the mother throughout the different steps, and the timing of the fluid and blood products given. Debriefing, an opportunity to discuss the events surrounding the obstetric hemorrhage, should be offered to the woman, possibly with her birthing partner or partners, at a mutually convenient time. After obstetric emergencies, women can be psychologically affected by postnatal depression or fear of further childbirth. Major postpartum hemorrhage can be traumatic to women and their families and has been associated with the subsequent development of post-traumatic stress disorder. Women who have experienced a major postpartum hemorrhage should be offered an opportunity to discuss the events surrounding their delivery. A discussion of future pregnancy, including the likelihood of a repeat postpartum hemorrhage and any fears regarding pregnancy and childbirth that the woman may have, should be addressed. This should include arrangements for appropriate investigations as necessary, such as testing for coagulopathies if there are other indicators, and screening for the rare complication of postpartum hypopituitarism or Sheehan syndrome, secondary to hypotension.